Well, I am very honored and very pleased to give this lecture. And I understand that the timing is very difficult for you, and it is just wonderful to see so many bright young people. The condition that we're going to talk about, hypertrophic cardiomyopathy, is very interesting. And I think that it's been around for a long time. I have discovered three separate case reports out of Paris in 1869 of patients who had this. They had no idea what was going on, but in looking back at these cases, they had it. They had HCM in 1907, so that was 1869. In 1907, a German cardiologist carried out an autopsy on two women who had marked cardiomyopathy, and they came to the conclusion that there must have been an obstruction. This was long before cardiac catheterization. Now, the modern look at this after another half of a century came about in 1957 and 1958. So in 1958, this paper was published in the British Heart Journal, and Donald Tier was a pathologist at a teaching hospital in London, and he reported 8 cases of asymmetrical hypertrophy, and he said he thought there was a muscular hamartoma of the heart, and the hamartoma refers to a benign but enlarging tumor. The pathological picture under histology was a bizarre and disorganized arrangement of bundles. So that was a key observation. 1, 2, 3, 4. This is the key photograph of one of these 8 patients. And as you can see, in the center is this enormously hypertrophied interventricular septum. And to your right is the free wall of the left ventricle, which is only modestly hypertrophied. And you could see the mitral valve between the interventricular septum and the left ventricular cavity. On the left side of this photograph is a small right ventricle. So this is the condition we're dealing with. 1, 2, 3, 4. Now, we were approaching this from a different point of view. So you saw the pathology. Now, from our point of view, these were the early years of open heart surgery. And at that time, in 1957, 58, I was working at the National Heart Institute on the east coast of the United States, in a state called Maryland. I was working in the cardiac catheterization laboratory, and this is what we obtained with a catheter in the left ventricular cavity, and then it was withdrawn into the outflow tract and then into the aorta. So you can see that there is an obstruction that was in the cavity in the outflow tract and no obstruction between the outflow tract and the aorta during systole. Now, as I said, these were the early years of open heart surgery, and we looked for patients who might do well at surgery, not the highest risk patients. And we came to the conclusion that this patient had a membrane, had a congenital subaortic valvular membrane. And we thought that that would be a relatively simple operation on the heart-lung machine. 1, 2, 3, 4, go back. Okay, so this is a picture of my colleague. We were really partners. I was in the cardiac cath lab, and this is Andrew G. Morrow, who was the chief of cardiac surgery. We worked closely together. And so the patients whose catheterization of the left ventricle you just saw, he agreed that membrane could be opened. And he called me to the operating room, and he was very disturbed because he opened the heart and found no obstruction. And he was puzzled, and I was puzzled. And all I could say to him was, we found the obstruction, and maybe when you get the heart started, you might want to put a needle into the left ventricle and see if there's a gradient or not. I went back to the cardiac catheterization laboratory, and he came down about 2 hours later, and he said, yes, he said, it's very strange. You know, we opened the heart, we didn't see the obstruction. It was somewhat hypertrophied. I don't really know what's going on. And we puzzled about this for several weeks. And then a second patient showed up with exactly the same thing. They were both males, they were in their 20s, and we brought them back and did angiograms and saw that there was an obstruction in systole. So we brought them back and published the paper, described these two patients. And what we said is here, the obstruction to ventricular outflow is of such a nature that it is only operative in the contracting heart and was not apparent during the diastolic paralysis induced by potassium citrate. And here's the key sentence. These features can only be explained by muscular hypertrophy of the left ventricular outflow tract of sufficient severity that flow is actually impeded during contraction. We gave it, as you heard from the professor a moment ago, we called it functional aortic stenosis, which in retrospect was not a very good name because they didn't have aortic stenosis, but they had the function of that. And then it was changed to IHSS, and now it's hypertrophic cardiomyopathy. Now, what we found that in the following weeks, we saw a number of patients with this. And this is a catheterization that I carried out of 3 siblings. And as you could see, they all had the same thing. As the catheter was withdrawn from the left ventricular cavity, you can see the intraventricular obstruction, and then there's no problem with the aortic valve. And the top 2 panels represent 2 sisters, and their brother is the lowest panel. And all 3, you could see, had this same hemodynamic changes. And we concluded from this that this was obviously a genetic findings. And we'll go into the genetics a little later in this talk, but I wanted you to see this. Now, one of the very interesting early findings that we had were the hemodynamic alterations in what we then called idiopathic hypertrophic subaortic stenosis. Here is an example of a patient, and you can see the date of the catheterization I did was in August 1962. And the panel on the left shows the patient with no obstruction at all. And then he was given in the cardiac cath lab isoproterenol. As you know, that's a beta adrenergic agonist. The paper speed is slowed down. And in panel C, you can see the patient had a huge gradient. So this is an example of a patient with a sympathomimetic drug that caused the obstruction. And this can also be produced by the Valsalva maneuver, and as well as muscular exercise. So anything that makes the heart smaller increases the obstruction. Anything that makes the heart larger relieves the obstruction. And you will see this repeatedly in this talk. This takes us to 1963, another year from the previous paper, in which we discovered patients who had hypertrophy and no obstruction to blood flow. And we now recognize that about a third of the patients who have this condition, hypertrophic cardiomyopathy, do not have obstruction, even if we try to provoke it. And so that 1/3 is requires much more attention. Now, you saw the effects of sympathomimetic drug isoproternol, and that immediately raised the question of what if you block the beta adrenergic receptors? And we found that a propranolol, which is a beta adrenergic agonist, increased beta adrenergic blockade, removed one of the key symptoms in this condition. They often present with angina pectoris because of some thickening and decrease of the opening of the coronary arteries, the middle and the mid hemodynamic change. And the exercise was markedly improved by propranolol. And the guidelines, since this was done in many more patients since then, suggested, gave a very high recommendation to use beta blockade of patients. The other method of treatment was surgical. And this was a paper that was first authored by Dr. Morrow, whose picture you saw. And we were still calling it idiopathic hypertrophic salivary stenosis. And this was the operative treatment that Dr. Morrow developed. So as you can see at the top left panel A showed a special knife that he developed. It has two blades run parallel. You can see they are on top of the large septum, and large septum which is responsible in large part for the obstruction. And then you can see in panel B on your right, then he has his index finger in the area where the knife came in. And then at the bottom in the CD is a rongeur that shows the muscle that is removed. So this surgery is called a myectomy. And panel E shows the removed area, which no longer causes the obstruction. Now, in 1968, 10 years after our observations and 10 years after the pathology that I showed you from London came out, I left the NIH to go to California. And at that time, we had 126 patients. And before leaving, I wanted to get a feel for those. Now, 126 at that time in 1968 was a lot of patients. Now, in our centers, we see many, and I'm sure you do also. You might see 126 patients, not in 10 years, but maybe in 10 days. Now, as we follow these patients, we found that 10 of them had died. So there was a mortality of 8%. But it's interesting that 6 of these were sudden deaths. They were unexpected, and there were patients had been symptom-free, and the most common cause of death was sudden. And of course, this has been confirmed in much larger series. So looking back on this, here are 8 definitions that we found for HCM. 1958, the obstruction secondary to muscular hypertrophy. By 1960, as you saw, there was a familial association with an autosomal dominance. In 1962, when I showed you the patient who responded with more obstruction provoked by isoproterenol, showed the variability of the obstruction, and this is a real key to it. In 1963, a year later, was our paper on the non-obstructive form. 1964, the medical treatment with beta blocker. Also in 1964, the surgical treatment, the myectomy. And I did not show you the impaired left ventricular filling, which is an important component. And in 1968, the frequency of sudden death. So those were the definitions, really, that we put down for hypertrophic cardiomyopathy. So as you heard a few minutes ago, the Seidmans, which is a wife-husband team, have done important basic research in this condition. And it is considered to be a sarcomeric abnormality. And this diagram shows the myosin fiber at the bottom in green, and the actin thin filament at the top. And the 8 mutations are seen. There are 2 that are surrounded by oval red lines, and they refer to the genes that are present. All 8 of these are mutations which produce HCM, but the 2 big ones are shown in the red ovals. Well, this takes us from the past to the present time. So Here is an interesting paper, series of papers that says hypertrophic cardiomyopathy is not rare, but it's clinically underdiagnosed. We see that it's present in males and females about the same. All races have been shown, and all ages in all places. So this is a global problem. There are no countries and no segments of countries that haven't been shown. The estimated prevalence of HCM in the Western world, that would be in Europe and in America, the prevalence of HCM is about 1 in 500. So that would mean that in the United States, that there might be close to 1 million people, maybe certainly more than 700,000 patients. The median age of diagnosis has been in the middle 40s. And thinking is that any patient who is diagnosed, that there probably are 2 others who have this condition, and they have not been, they've been missed. The potential for Europe is 1.3 million Europeans with this condition. All right, so we then go on to the genetics and how the genetics has affected management. So a team under Dr. Green, again with the Seidmans in their laboratory and the company, they identified in 2016 a small molecule, which the name of the company was myocardia, that reduced contractility by decreasing myosin ATPase. It reduces contractility by decreasing myosin ATPase. And they demonstrated that this molecule suppresses the development of ventricular hypertrophy and cardiomyocyte disarray in mice harboring a heterozygous, a human mutation in the myosin heavy chain. This drug is called mavacamten, and here is its mechanism of action. So if you look at the top panel on the left, you see the normal relationships between actin and myosin. And you see that the myosin myofibril is in blue, the actin is in red. And you see the 2 of them connected. Those that are connected are shown as red. And you see that this field showed the normal sarcomere with 4 connections. In HCM, you can see the connections are much greater. And these hearts are not only hypertrophied, but they are hypercontractile, and they have impaired relaxation, which I mentioned. When they are treated with mavacamten, and you see that in your panel on the right, the number of ridges in red have decreased. They've not been made normal, because normal are on the left, there would be 4, but they are much better than in the center. So these are the HCM sarcomeres with mavacamten, and they have been markedly improved. So as you see at the bottom presentation, mavacamten is a first-in-class targeted inhibitor of cardiac myosin. So it reduces the number of myocyte-actin cross bridges and thereby decreases contractility, which is characteristic of HCM. Okay, so now let's see what this does for patients. This is a phase 3 trial that was published in the Lancet British Journal in the year 2020. And mavacamten, you've seen the basic science, has been used for treatment of symptomatic obstructive hypertrophic cardiomyopathy. And the paper was called Explorer HCM, which was a randomized, double-blind, placebo-controlled trial. It was found in this trial that treatment with mavacamten improved exercise capacity and reduced obstruction and improved New York Heart Association functional class in patients with OHCM, that means obstructive hypertrophic cardiomyopathy. Now, here are 3 panels, and remember, I said that they were placebo-controlled. The duration of the trial was 30 weeks. The top panel, panel A, shows in red the gradient, the alpha gradient that is between the cavity of the left ventricle and the systemic arterial. And you can see that there is no change. It went from 51 to 46. The patients shown in blue are the patients who were treated with mavacamten. And you can see that the gradient is markedly reduced in these patients. Panel B is similar. We use the Valsalva maneuver frequently to bring out a gradient. And so the gradients are higher in these patients with the Valsalva maneuver than they were with the patient at rest. However, you can see the difference that the gradient really declined from 73 to 25 in the MAVA patients, and decreased only slightly in the placebo-treated patients. And panel C is very important because it shows the exercise. And again, 30 weeks of placebo in red, there is only a minor reduction of gradient, but in blue are the patients, identical patients who were treated with mavacamten, and their exercise improved quite markedly. The gradient during exercise fell from 85 to 38 during exercise. Now here we come to something very important, and that is the Chinese patients who also carried out a phase 3 trial. And we're so pleased to have this kind of data. So this is an effect published in the JMA Cardiology Journal. So this shows the effects of mavacamten on Chinese patients with symptomatic obstructive hypertrophic cardiomyopathy. And so this has been called by your colleagues in China the Explorer CN for China randomized clinical trial. So, and here you see the results. Again, you see the placebo patients in red, and they stayed the same for 30 weeks. And you see in dark blue the mavacamten treated patients, and you see that the resting gradient really went way down. So this is a very important finding, because sometimes, no matter how hard you try, sometimes these clinical trials need to be repeated if you're going to make and subject many, many patients to the drug. And therefore, it is very important to us to have done this study in another country. And we have the highest respect for the work that is going on in China in cardiology. And it was very important to do this trial and to find basically the same thing. If anything, it was even more potent in China than it was in Western Europe. So we go on, and mavacamten then is the first-in-class myosin inhibitor for obstructive hypertrophic cardiomyopathy, and it's now used quite widely. Now, this class of drugs looks like it's very important. This is the second Campton, avacamten, you would have to say, is a sibling of mavacamten. And it also, as published about 2 years after mavacamten, also published in one of our journals, New England Journal of Medicine, symptomatic obstructive hypertrophic cardiomyopathy. The primary endpoint in this trial was exercise capacity, in addition to the gradient, how fast and how much oxygen can the patients present. On my graph here, you can't see the right portion of the red line, but you have to take my word for the fact that there was a marked increase in the peak oxygen uptake. That means the patients were so well that they improved markedly. That's in orange. In blue are the placebo-treated patients. There was no change in oxygen uptake. So here is a series of graphs of aficamten, the second drug. On the left, you can see the bulging of the interventricular septum, and you can see that there are many bridges that connect the actin and the myosin. On the right-hand portion of this slide, you can see that with aficamten treatment, there are relatively few bridges that really connect. On the left-hand side, the sarcomere has 4 connections. On the right-hand side, only 2. So these are reversible. If you stop the drug, the obstruction returns. So when they're on the drug, there's a reduction of left ventricular outflow tract, an increase in end-systolic volume, a reduction of left ventricular wall thickness, and an improvement in diastolic filling, and aficamten, as you can see, improved multiple structural and physiologic parameters. And at the bottom, you see changes in echocardiographic measures are associated with changes in maximal oxygen consumption with aficamten-treated patients. Actually, the 2 camtons are quite seriously similar. That's why I call them siblings. And now we look at the future. We've come a very long way from findings that I mentioned at the beginning, the obstruction that was found, and also the finding of the absence of obstruction in about a third of the patients. And the importance of the genetics and where are we going from here? Well, I'm just going to show one slide, and that what's going on now is the future shows what we're into now, and that is the prevention of HCM. And there are two areas. The first, you had a hint of the creation of mice with human HCN genes, and that's key. So we call them HCM mice. And the prevention is to replace the mice of mutated with the human genes that encodes one of those orange myosin binding proteins, which increases cross bridges. And that work is going on now. So you have a good model in a small rodent in mice, but at the same time, this company called Tenaya, which is in California, has now engaged patients with HCM, and this trial is going on in patients who don't know the results yet, but we're optimistic because the changes in patients have been seen in the mice, and certainly the mice have responded to the treatment with mavacamten. So we're hopeful that we will find this in patients as well. And then we come to the artificial intelligence. There is a company also in California which has been by have been approved for identifying individuals who have HCM. So basically new artificial intelligence for earlier detection and management of hypertrophic cardiomyopathy is likely in the future. So this is my last slide, and I appreciate your attention and would be pleased to try to answer key questions. Thank you.
Dr. Braunwald, that was spectacular, simply spectacular. And I'm letting you know that so far, I'm told there were over 5,000 people listening to your talk, and I virtually guarantee that number is going to go up. And I'll also point out, as you know, that Professor Wang Jianan, right there in the front row, was one of the authors on that important mavacamten trial in China, right here in the audience, and the president of the second affiliated hospital. So we have several questions that are coming in. First, AJ Marion from Houston has a question.
Thank you, Dr. Hill. Dr. Braunwald, it's a true honor, it's a great honor to have the opportunity to listen to you and learn from you, someone who really have established HCM the way we know it today. My question to you relates about what I consider a disparity on the effect of so-called myosin modulators in reducing left ventricular outflow tract obstruction, which is quite remarkable. They effectively reduce the outflow tract obstruction. However, the clinical effect of these drugs, in my opinion, is quite modest. Even in Explore-HCM, only a third of the patient reached the primary endpoint, which was really a soft endpoint of maximum oxygen consumption and improvement in New York Association functional class. And the improvement with oxygen consumption, both with mavacamten and aficamten, was less than 5% of the baseline. To me, that's quite unremarkable. So what accounts for disparity in reducing the LV outflow tract obstruction, which is quite remarkable, and yet clinical effects, which in my opinion is quite modest? And if so, what is the next phase beyond gene therapy and base editing? Thank you, sir.
Well, I think you make a very good point. I think that these drugs need to be used very carefully. I think that patients are quite different, and the ones that enter these trials, we show the average level, as you see, everybody that doesn't respond, we're still learning how to use them. I think that in terms of patients' feelings, I think that in both trials, the mavacamten and aficamten, the New York Heart Association classification moved up by one major step. I think there are other Camptons that are on the way. If we think about treatment hypertension, if you think about hypertension and the treatment of hypertension, the first drugs that became available lowered the blood pressure and improved the outcome, but not nearly as much as what we can do now. So the story isn't over. This is a big step forward, but it's not the final step. If you think back to when I was in training, there were no drugs that reduced blood pressure. Then some blood pressure drugs came along. They lowered the pressure by maybe 5 millimeters of mercury. Now you can reduce the blood pressure to any level that you want. And I think that you have to look at this the same way. This is the beginning. And I'm glad you asked that question. Give me the opportunity to mention this. I'm aware of 4 other companies that are making these compounds, and they get better and better. Same thing happened with statins and cholesterol lowering.
Thank you. So illustrating the international nature of the audience here, we have a question from Carol Previs in New York, please.
Oh, okay. What are your thoughts about pre-treating a patient with a mavacamten-like drug that already has aortic stenosis?
With aortic stenosis?
Yes.
And I'm sorry, what's the question?
My question is, what are your thoughts about pre-treating a patient with mavacamten that when that patient has pre-existing aortic stenosis?
No, I don't think there's any reason to think that that would be helpful. And I'll tell you why. Because in aortic stenosis, if you reduce the ejection fraction, they can go into heart failure because you've left the obstruction. The obstruction in aortic stenosis, if I catch you correctly, is in the valve. Calcification.
I guess I didn't. I apologize. I don't think I asked it correctly. A patient has aortic stenosis and obstructive HCM. And one possibility that's been presented is to pre-treat the patient with mavacamten to reduce the HCM and then treat the aortic stenosis. Is that something that you have thoughts about?
Well, I have to say that calcific aortic stenosis and HCM in the same patient, I've not encountered. I would have to think about this. I probably would want to attack the valve first.
Well, we are out of time for questions, but I'm going to pivot to Eugene Braunwald here, who has been the leader of this incredible initiative for some time. So, Eugene, please.
Thank you, Dr. Hill. Give me this great honor, and thank you, Dr. Braunwald. It's a tremendous privilege to witness the historic moment in our field. As a basic scientist, you showed us the journey of evidence-based medicine to break the pre-existing consumption of the disease. When you look at the HCM, and people actually looking at the stenosis as the only cause, and yet you actually break into genetics. And then when you look at the therapy, it's a mechanism-based therapy. Rather than increase contractility as most of the heart failure medicine, you actually elucidated from the mechanism that is decreasing the contractility is the solution. And all those really showcase the journey of discovery to therapy based on science. And it's truly inspiring. And hopefully we will learn from your journey to charter and to tackle new challenges in our field in many other diseases. And with that, I just wanted to say how much I am moved and by your dedication and your commitment, not just to the science, but also to education. And your mentioning of the great work from China, it was really heartwarming to us as well. So I wanted to also invite our host, Professor Jian Wang, to make a final comment. Professor Wang.
Okay, thank you, Carl. It's my great honor to express my heartfelt appreciation to Dr. Eugene Braunwald for your outstanding lecture on hypertrophic cardiomyopathy, which eloquently traces the remarkable journey of discovery, understanding, and therapeutic innovation in this challenging disease. So alongside with other contributors, you has made truly landmark contributions that have profoundly shaped our knowledge and practice in the field of cardiovascular medicine. So thank you all. Also thank you, Jill, and thank you, Yibing, and all of other attendees for your joining us. Thank you. Welcome you all to China, to our beautiful city, and to visit our hospital. Especially, the next month, at the end of the next month, we are going to have a big general cardiovascular conference, QICC. Some of you may not come this year, so we are looking forward. You're coming next year. Okay, thank you all.
Thank you.
Well, thank you very much, everybody. Thank you, Dr.
Thank
Braunwald.
you.
All my friends in China, enjoy the rest of your day. Go have breakfast.
Thank you. 那就关上。
Bye bye now. Bye bye.
拜拜，拜拜。
Bye bye. Bye bye.